Myself, Dr. Prince Chaudhary, second year radiology resident from Shiva Medical College and Hospital, Surendranagar. I am presenting a case in Case of the Week series under the guidance of Dr. Harshad Shah sir, Dr. Nirmala Chudasma ma'am, and Dr. Rajnikant Chauhan sir. Case history. A 53-year-old female patient presented to our department for CNS evaluation, referred by neurosurgery department with chief complaint of right upper limb weakness associated with headache since 15 days. The patient is known case of hypertension since 7 years and she is on regular medication. MRI images shows ill-defined irregular mass lesion involving choroid plexus of body of left lateral ventricle with involvement of left thalamus, left cerebral peduncle and anterolateral aspect of left-sided midbrain. Lesion appears heterogeneously hyperintense on T2 weighted images and hypointense on T1 weighted images. Few small scattered discrete flare hyperintensities is seen in bilateral periventricular white matter. On axial, sagittal and coronal, MRI post-contrast images show intense heterogeneous enhancement of lesion with non-enhancing areas within it. CT images shows well-defined round-shaped heterogeneous hypodense intraventricular mass lesion involving choroid plexus of left lateral ventricle, it compressing thalamus, cerebral peduncle and anterolateral aspect of midbrain on left side with perilesional vasogenic edema. Histopathological examination of lesion shows fibrous tissue with plenty of scattered round to oval cells without any distinct cytoplasm appears as nuclei. Few of cells shows seeds of spindle. Many of cells shows pseudoinclusion. Few cells showing mild nuclear atypia. Findings are suggestive of meningioma. Final diagnosis of my case is choroid plexus meningioma. Discussion. Intraventricular meningiomas are rare, accounting for only 0.5 to 3%. Mostly intraventricular meningiomas presented between third and sixth decade with male to female ratio is 1:2. Intraventricular meningiomas are rare thought to arise from meningothelial inclusion bodies located in tela choroida and or mesenchymal stroma of choroid plexus. Usually the location is lateral ventricle in 80% cases. As choroid plexus is bulkier in lateral ventricles, meningioma are relatively more common in lateral ventricle as compared to third and fourth ventricles. Anterior and posterior choroidal vessels are the feeders of these lesions. Clinical presentation: headache, seizure, neurological problem, nausea, vomiting, visual disturbance, cognitive and personality changes, and cranial nerve palsies. Treatment and prognosis: complete excision gives the permanent cure to the patient. Various surgical corridors to enter the ventricles are posterior temporoparietal, superior parietal lobule, posterior interhemispheric, transcranial. Shortest route to trigonal region is superior parietal lobule. If complete surgical resection is not possible or in cases with higher grade of meningioma, radiation therapy may be recommended to control the tumor growth. Shunt replacement for management of hydrocephalus is done. The prognosis of choroid plexus meningioma is generally favorable, especially with the complete surgical removal, but it can vary based on the tumor grade and location. Follow-up care is crucial for managing the potential recurrence. Thank you.